Solubility coefficients, oxygen is less soluble in CO2, but in the end, we actually end up with equal amounts of both gases within the blood and within the air. We looked at the way partial pressure impacts the diffusion of those gases, and it sort of depends on what elevation you're at or what's happening with your body. So the hyperbaric chamber, 100% oxygen, definitely going to go down its concentration gradient pretty quickly. And the reason for that 100% is to push out carbon monoxide or nitrogen gas, because those two are also in the gases that we breathe, CO2, CO, and nitrogen. And we know that when we climb in elevation, the atmosphere gets lighter. We have gases farther apart, so they're not as readily available, so they don't diffuse as rapidly. And our normal gradient at normal atmosphere 760 millimeters of mercury is pretty standard. We talked about how our gases get mixed up. So along the length of our respiratory tree, we have a mix of gases. So we can have a certain percentage gas of oxygen in the atmosphere, but then when we breathe it in, it gets mixed up with CO2. So we reduce the partial pressure of oxygen in the tubes and in the alveoli. And then we see a change in the partial pressures of CO2 from the blood to the alveoli. And we also saw a change in the partial pressures of those gases within the oxygenated blood. Remember me telling you about how the bronchial arteries meld with the pulmonary veins as they head toward the heart. So we get a mixing of those gases, and that reduces the partial pressure of oxygen in the oxygenated blood. And then this is where we came, right? Did we talk about membrane thickness? I think that's where we stopped. Yeah. So another factor that impacts our external respiration is whether or not we have the ability to diffuse across those membranes. And in fact, when you have a condition like pneumonia, where you get a buildup of fluid and blood within those spaces, diffusion is going to be impacted. So we definitely want a moist surface on the alveoli, but we don't want a ton of mucus and a ton of blood cells. We want a nice, smooth, simple squamous epithelium and a respiratory membrane that includes just the capillary endothelium, the basement membrane, and the alveolar plasma membranes. So this is a nice example of what happens when you have edema from pneumonia. I've had pneumonia. Anybody else had pneumonia in here? Yeah? Anybody else? Yeah? It was vicious. I've never been so sick in my life. It was hard to breathe. It was hard to, do anything. I was exhausted all the time because I wasn't getting enough oxygen, not making enough ATP, right? Then we have the membrane area. So we need to have those simple squamous epithelium attached to each other, so we have intact alveoli. But if they start to break down, then we get these big pockets. And what happens in those big pockets is that the CO2 gets trapped in those pockets, and that elevation of CO2 in the alveoli means that there's a backflow, what's the word I'm looking for? Flush of CO2. If we can't get rid of the CO2 in the alveoli, we can't get rid of it in the blood. And what does that do then? We have an increase in hydrogen ion concentrations. And your medulla oblongata is saying, breathe, you need to breathe. And you can't, because you can't get rid of that extra CO2. You have big pockets. Did anybody watch that video over the weekend, the FEV one, the FEV? Wasn't it interesting?
It was, but it was a lot of information.
A lot of information, so I recommend you watch it several times, because it's going to make more sense each time you watch it, especially now that we're talking about it. Yeah, so when you have this lack of surface area, then you have a lack of the ability to diffuse. Can't diffuse the oxygen in, can't diffuse the CO2 out. Another thing that can happen is that you have this ventilation perfusing coupling has got to be in sync. You have to be able to perfuse the blood, and you have to be able to ventilate from the blood. They have to match up. And it's nice that it works out really well. As it says, that your vasoconstriction is going to happen in a segment if the blood flow is reduced. Thus, you're going to have a lower partial pressure for oxygen. Makes total sense. And if your ventilation increases, then you're gonna see a partial pressure of oxygen increase. So your blood flow is gonna match that. But if you don't have that flow of blood matching the perfusion, things go awry. So those are things that affect external respiration. Membrane area, membrane thickness, your partial pressures, your solubility, and your ventilation perfusion coupling. Now, we're gonna go to oxygen just briefly, and then we're gonna continue on talking about CO2, because CO2 is a little more complex than oxygen. You remember from 232 that oxygen is dependent on hemoglobin to carry the oxygen. Remember that? From the circulatory system, blood. Right, so it's pretty easy to understand that hemoglobin is essential for moving oxygen. We breathe oxygen in, it binds to hemoglobin, and then it leaves that hemoglobin, drops off to the tissues. We have this thing called the hemoglobin saturation curve, and what I want you to notice here is that our saturation of hemoglobin is quite low when our tissues are exercising. When our tissues are at rest, it's about 40 millimeters of mercury. Saturation about 73 to 75%, meaning that when our tissues are at rest, our hemoglobin is going to hang on to more oxygen. When our tissues are working, hemoglobin readily drops that oxygen off. It doesn't even, it's ready to give it up. So hemoglobin and the attraction of oxygen is based on tissue activity. The more you're working, the more you're exercising, the more you're working your tissues, the more oxygen they need, hemoglobin's ready to give it up. That's all this is about. So we see here oxygen released to the tissues at rest about 23%. That means that our hemoglobin is hanging on to that oxygen because our tissues don't need it. When our tissues are exercising, hemoglobin gives up that oxygen readily and our saturation is much reduced. And the saturation is talking about hemoglobin hanging on to oxygen. That's what oxygen saturation means, or hemoglobin saturation means, is that the hemoglobin is either giving up the oxygen or hanging on to it. So the lower the demand for oxygen, the more saturation we see of hemoglobin. The higher the demand for oxygen, the lower hemoglobin saturation occurs, because it readily hands it off, readily gives it up. That's all this is about. Exercising tissues, low saturation. Resting tissues, moderate saturation. These guys are going to be unloaded to resting tissues. The rest of this stuff is actually referred to as the venous reserve. So let's say you have something happen to you, you have a head injury, you're knocked out, or you have a cardiac event and blood isn't flowing, you have a little bit of reserve of oxygen in the blood to take care of those moments for your tissues. The venous reserve, 4 to 5 minutes to sustain life. So that's all there is about oxygen. It's pretty simple to understand. Hemoglobin carries oxygen. Remember that each hemoglobin molecule carries 4 oxygen molecules. Do you remember the statistics for that? How many billions of oxygen molecules red blood cells carry?
Like 2 something or 1.
There it is. I never remember the exact. So a single erythrocyte contains 280 to 300 million hemoglobin molecules. Is that crazy to think about? And a red blood cell is so tiny. 200 to 300 million hemoglobin molecules, and so you multiply that by 4, you come up with more than 1 billion oxygen molecules in every red cell at full saturation. We're talking total saturation, which probably never happens. And then we have 3 to 5 million red cells per cubic millimeter. Remember that from 232. The cubic millimeter, 1 millimeter high, wide, deep. 3 to 5 million red cells. So there's a significant supply of oxygen for the most part. All right, so next thing to talk about is carbon dioxide. How do we move carbon dioxide around? It's a little bit more complicated than your simple oxygen hooked it onto hemoglobin, being dropped off by hemoglobin, hey, picking up, right? A little bit more complex for CO2. We have essentially three means for moving CO2 in the blood. And as you can see here, about 20 to 23% of carbon dioxide is moving through the capillaries and attaches to hemoglobin. So we got a little of it that's readily attached to hemoglobin. We have 7% or so that is dissolved in the plasma, so it's just carried along in the blood in the plasma as a gas. And then the most of it, the vast majority of our CO2, is picked up by the red blood cells. There's an enzyme in the red cells called carbonic anhydrase. And carbonic anhydrase will bond CO2 to water and form carbonic acid, H2CO3. Carbonic acid is then dissociated into bicarbonate ions and hydrogen ions by the same enzyme. The hemoglobin that has been released, it's released its oxygen, right? It's dropped its off the tissues. CO2 is coming from the tissues into the blood. That CO2 enters into the red blood cells, is forming carbonic acid, and then that carbonic acid dissociates into hydrogen and bicarbonate ions. The hydrogen ions, given that we have enough room, is going to be picked up by the hemoglobin, or the hemoglobin is going to take up the hydrogen ions because it's got room. It doesn't have any oxygen to carry. The bicarbonate is going to be shipped off into the blood. And it's shipped off into the blood by something called a chloride shift. Chloride shift means that when we ship the bicarbonate into the blood, into the plasma, we have to bring a negative ion back into the red cells because we have to have balance, right? So the bicarbonate is a negative ion, hydrogen ions, positive, chloride, negative. So we're going to take the bicarbonate ions, ship them into the plasma, and we're going to bring chloride into the red cells until such time as we get back to picking up oxygen and dropping off CO2 at the lung level. So hang on to this, we're going to talk about this next. This is the tissue level of the system. This is our blood. Here's our red blood cell. What's happening in the tissues? The tissues produce a lot of CO2. The CO2 could either be dissolved as a gas, it could be hooked onto some hemoglobin called carboxyhemoglobin, or the vast majority of it is going to be shipped into the red cell, bound to water, forming carbonic acid via carbonic anhydrase. That carbonic acid dissociates into bicarbonate ions and hydrogen ions. And then we have this thing called the chloride shift. The bicarbonate ions are shipped into the plasma, chloride ions are shipped into the red cell to keep our balance of negative and positive ions within the blood. Everybody see that? You'll have to think about this a bit.
So then it goes to the lungs and we breathe out.
Hang on. Hang on.
Okay.
We're still moving the chloride,
Okay.
moving the carbon dioxide.
Yeah.
All right, so the CO2 plus water, carbonic acid, dissociates into bicarbonate ions out to the plasma. Hydrogen ions then are combined with hemoglobin to form deoxyhemoglobin. Deoxyhemoglobin. Oxygen into the tissues frees up the hemoglobin to pick up the hydrogen. Tissues work, do their thing, produce CO2. CO2 delivered to the red cells, dissociated into carbonic acid, or associated in carbonic acid, dissociated into bicarbonate out to the blood, hydrogen into hooked up to hemoglobin. Then we get to the lungs. The blood's circulating through, remember, red cells circulating through, passing through, how long was it? 0.3 of a second during exercise, 3/4 of a minute to get through the whole system. Pretty remarkable. At the alveolar level, here's our red blood cell. Remember that our red blood cell at the alveolar level is loaded with CO2 hydrogen, really, hydrogen ions. Right, so at the alveolar level, our partial pressure for oxygen is high in the tissue, in the alveolus. Diffuses down this concentration gradient. It displaces the hydrogen ion because hemoglobin has an affinity for oxygen. The hydrogen ion is released. The hydrogen ion binds to bicarbonate, because now we're doing the opposite. Bicarbonate shipped in, chloride shipped out, chloride shipped. Hydrogen plus bicarbonate yields carbonic acid, carbonic anhydrase, both sides, to CO2 and water. We breathe them out. Because every time you breathe out water vapor. You know this because when you breathe on a piece of glass, your mirror, your glasses, you get fog. That's water. So, at the alveolar level, oxygen, high concentration, diffuses down its concentration gradient, is picked up by hemoglobin, and carried off to the tissues. At the tissue level, that oxygen is released to the tissues. At the tissue level, we have a high concentration of CO2. It's picked up by the red cells, converted to bicarbonate hydrogen ions. Hydrogen stashed here. The bicarbonate is shipped out there. A little bit of the CO2 hooked up to hemoglobin on its own, and some of it is cruising around just as a gas in the plasma. That's how carbon dioxide is moved around. CO2 from the red blood cells to the alveolus, oxygen from the alveolus to the red cells. And on and on and on it goes. 12 to 15 times a minute, you're seeing this kind of exchange. Not all your red cells give up all their oxygen every single time you pass through a tissue. Remember, we have that reserve. You're at rest here. You have no need for that extra oxygen. It's being carried around nicely, taken care of by your red cells until you need it. When your tissues are exercising, when they are working, and they require more ATP, where do we get the ATP from? We burn glucose. What's oxygen have to do with glucose? Does anybody remember this? Why do we need oxygen?
For aerobic respiration, the production of ATP.
The production of ATP is the result of the citric acid cycle
Yeah.
and the electron transport system. Pyruvate, yes. And so when you have these glucose molecules, but it's oxaloacetic acid at that point, as it's going through that citric acid cycle, the carbons are peeled off. The carbons are peeled off. They have to be picked up by something. They're picked up by oxygen. Boom, CO2. Hydrogen ions are freed as well, because when we take the carbons off, we release hydrogen ions. They're used to make NADH and FADH, the coenzymes, which are little fairies. And fairies are carrying those ATPs, or those hydrogen ions, to the electron transport system to create ATP. That's why you needed to learn about cellular respiration, so you could understand this. What happens to our CO2? It's a byproduct of cellular respiration, and we get rid of it through the respiratory system. There are things that alter our oxygen, hemoglobin's oxygen affinity, and the things that alter our hemoglobin's oxygen affinity or hemoglobin saturation include our pH, temperature, hormones, partial pressures of oxygen. All of these things are going to drive that oxygen affinity. Let's see, which one of these is our typical normal pH? Here we are at 7.4. Here's a little lower pH, so a little on the acidic side. Here is a more basic pH, and this is just showing you how our partial pressure of oxygen is impacted by changes in pH. Normal pH, here we are at 73, 74%. But if we lower the pH, what happens to our oxygen affinity? It's lowered as well. What would cause a lower pH?
Higher hydrogens.
Hydrogen ion concentration, where does that come from?
The conversion of carbonic acid.
Yeah, so if we have more carbonic acid, where did that come from? CO2 plus H2O, right? So when you produce a lot of CO2, that's telling your body your tissues are working. If your tissues are working, your hemoglobin is going to have a lower affinity for oxygen than when your tissues aren't working so hard, because you need to drop off that oxygen to those working tissues So the oxygen to pick up the extra carbon that's produced from the citric acid cycle, that is the result of cellular respiration, that's been increased because you need more ATP. No? Gotta think about it. Think about it. Decreased pH. Tissues are more active. Your oxygen binding curve shifts to the right. There's a name for it. Somebody named Bohr identified it originally. As the pH lowers, the affinity for hemoglobin to oxygen is decreased because we need oxygen to take those carbon molecules that are increasingly being produced as we make more ATP more quickly. Why do we need the ATP? Because your tissues are working. You need the energy to drive that work. Yeah. And other things that affect our oxygen affinity. Body temperature. This is going to relate to that exercise thing. Here's our normal body temperature, 38 degrees centigrade, 98.6-ish for Fahrenheit. When we increase our body temperature, look at what happens to our affinity. It shifts to the right. Why do we have an increase in temperature? What would cause an increase in temperature?
Exercise.
Exercise, exactly. And if you are exercising, what do you need more of?
Oxygen.
Oxygen. Why do you need the oxygen?
Energy.
To burn the glucose, right? To peel those carbons off the glucose to get the hydrogens, ultimately, to the electron transport system. Because it's the hydrogen ions that drive the production of ATP. So, when we increase our body temperature, we have a lower affinity for oxygen via hemoglobin. Very interesting. Epinephrine. Where would epinephrine show up? Why would epinephrine have anything to do with oxygen affinity?
Adrenaline?
Adrenaline. And when's adrenaline pumped up?
When you're
Woo-hoo-hoo.
active or afraid
Right? You
or
may not be
running.
moving anywhere, but you got stuff burning. So epinephrine is going to lead to a shift to the right for affinity. Oxygen is going to have, hemoglobin is going to have a lesser affinity for oxygen when you're in a fight or flight mechanism, fight or flight stage. All right, testosterone. Testosterone. Increases EPO production. What's EPO? Erythropoietin. And that means you have increased red blood cell production, which means you have an increase in this thing, this molecule called bisphosphoglycerate. And bisphosphoglycerate is produced by red blood cells. It's an intermediate, sorry, it's not produced by red blood cells. It is in red blood cells, impacts red blood cells' ability to bind to oxygen. So it's part of the glycolysis and citric acid cycle, intermediate as it says, to glycolysis. It binds to hemoglobin and thus causes oxygen to be released. And that's pretty much the system until you get more oxygen. Then hemoglobin picks up that fresh oxygen. This is kind of interesting. Have you donated blood? Mm-hmm. Right? You donate blood, you know that blood is only good for so long, which is why they're constantly looking for supplies of blood. And the reason that that blood is only good for so long is because BPG, this bisphosphoglycerate, drops. And then there's no binding of oxygen to the hemoglobin. And there's no use in keeping those cells. Or it's actually that the red cells don't release the hemoglobin, that's what it is. Yeah. So, things that impact oxygen affinity. pH, become more acidic, shift to the right. Temperature, gain temperature, shift to the right. Testosterone, growth hormone, thyroxine, all of these things can impact the red blood cell's ability to hang on to oxygen. And we've already talked about this quite a bit, so I feel like it's almost like beating a dead horse, but it's worth repeating that your pH is related to CO2 plus water yields carbonic acid, which yields hydrogen ions and bicarbonate ions. And that is then going to increase the likelihood that hydrogen ions are going to drift from the blood, from the red cells into the blood, and from the blood to the cerebral spinal fluid. And when it hits the cerebral spinal fluid, your primary driver of respiration is pH. The lower your pH, the more your body says you've got to ventilate. Why do you need to ventilate? You gotta get rid of that extra CO2 because it's what's gonna produce those extra hydrogen ions. That's the way it goes. We have receptors. We have peripheral and we have central chemoreceptors that help us determine what our blood is consisting of and whether or not we have the right blend of oxygen and CO2. As you can see here, our central chemoreceptors are capable of detecting pH, but they also can detect changes in oxygen concentration, CO2. More peripheral receptors, chemoreceptors. And as we already discussed here, the pH decreases, our respiratory rate is going to go up, and the whole purpose for this is what?
Get CO2 out.
Get rid of CO2, exactly. CO2 ultimately, as you can see here, is the driver. I mean, it says up here the pH and CO2, the primary drivers of respiration, but it's because of that hydrogen ion that comes from the breakup of carbonic acid, which comes from CO2. So you got to remember all of that. Remember all that. Things that can cause us problems with our lungs are usually divided into two kinds of lung diseases. One is obstructive lung diseases, the other is restrictive lung diseases. As a general rule, obstructive diseases make it more difficult for you to inhale. Exhale, sorry, exhale, that's the one, yeah. Another one of those brain crabs. Obstructive respiratory diseases make it more difficult for you to exhale. I have to remember that from emphysema. And then the restrictive lung diseases impact your ability, basically, for inhalation. There's a couple of different conditions here. These got this COPD, you've probably heard of COPD. And COPD includes emphysema and chronic bronchitis. And bronchitis would be inflammation of the bronchi and the bronchioles. And when you get inflammation of those tubes, that's going to impact the ability for you to move gases, especially out. And emphysema, do you remember what emphysema is about?
Air in the lungs.
In the lungs, lacking surface membrane.
Oh.
So you have bigger right pockets. Whereas what that video, the FEV1, obstructive versus restrictive lung diseases, describes it as carbon capturing or carbon trapping, CO2 trapping, air trapping. So CO2 just swirls around in those big pockets and you can't move it out because you can't breathe out. And you can't move it back into the tissues because it's already being still built up in the tissues. Our cells never stop. 24 hours a day, 7 days a week, our cells are working and producing CO2. Never stops until you stop. Keep that in mind. We got asthma. Asthma, that is an inflammation of all of our tubes as well, and a restriction, like clamps right down. You get a asthmatic attack, nothing moves. Bronchiectasis is, and I have to remind myself of that one all the time, so I have little notes down there for bronchiectasis. It is also involving the bronchi. There it is, bronchial tubes. There's chronic, actually permanent damage to the bronchi in bronchiectasis, and those damaged airways, of course, are susceptible to bacteria because we're not able to move things around, get build up of mucus, so we have passageways that are capable of buildup of bacteria. And then cystic fibrosis. Do you remember what that is? Anybody?
It's the mucus production.
Yes.
Excess mucus, and it's really thick.
Yes.
And it also makes it hard.
And it's a genetic condition, right? It's a homozygous recessive genetic condition, cystic fibrosis. Yeah, so you get a buildup of mucus, really thick, hard to breathe. Then we have on the restrictive side, pneumonia. Actually, pneumonia. Very difficult to inhale because you got all of that mucus and blood pooling in your alveoli. Hard to get things moving back and forth. Interstitial lung disease, you can just imagine what that is, interstitial in between the tissues. Idiopathic pulmonary fibrosis, they don't know where it comes from. Sarcoidosis, do you know what sarcoids are? They're growths. So imagine having little sarcoids, little tumorous growths in and around the lung tissue. It's going to impact your surface area and your membranes, all of that. So it's going to impact your ability to breathe in. The obesity. What about obesity? Why would obesity be considered problematic?
It restricts your mobility, your muscles, your articulations, and it's just harder to do.
Yeah, so if you have adipose tissue all around your heart, probably pressing up against your lungs. You have adipose tissue abdominal, impacting how your muscles work, adipose tissue everywhere. Plus, people who are obese tend to not move very well. And not moving means that you get CO2 buildup. So you gotta blow it out. Right? Yeah. And then scoliosis. Do you remember scoliosis from 231? Had several different kinds of scoliosis. Got your lordosis. Lots of young women have lordosis. Straightens out. I had lordosis when I was younger, but it's gone. Kyphosis. The little widow's hump. That's kyphosis. And then scoliosis, where the vertebral column does something like this, yeah. How would that impact your respiratory system? Right? It's going to impact how your ribs are lifted up and out. Maybe you can't lift them up and out because you got a severe curvature in that region of the spine.
So that's kind of similar to what you were saying with the sternum. It's just the same type of like,
Impact.
Okay.
It would impair
Okay.
your ability for full function of the thorax. And then you got neuromuscular diseases. Why would neuromuscular diseases be a problem?
So you need muscles to.
You need muscles, right, to lift your ribs up and out and to drop your diaphragm and be able to move those things. Yeah. So that's things that can cause problems in your respiratory system. This is just a way of looking at some of those respiratory diseases. So this is an image of pneumonia. There's a section of that lung that is just filled with fluid. And of course, that's going to interfere with gas exchange. So what you develop is something called hypoxia, you have low blood oxygen. When you're low blood oxygen, what aren't you making? What can't you make without oxygen?
ATP.
Can't make ATP. Exactly. Right. Immunocompromised people, really old people, really can be impacted by this. So what really happens to old people is, especially women, old men too, you get osteoporosis. You break a bone. You end up in the hospital. Now you're not moving. And you're in a highly bacteria-ridden environment. You get pneumonia. Toast.
Muscle atrophy.
Muscle atrophy. Even if you're there that long.
Yeah.
You might not even be there that long. Right. Okay. So alveoli filled with yuck, and you get a thickening of your membranes, and pneumonia can kill you. How about tuberculosis? Have you heard of that? Kind of, sort of. Mm-hmm. So we're lucky in this country. We don't have a lot of tuberculosis. However, there's a lot of international travel, and so there is the possibility of getting tuberculosis. Tuberculosis happens from a bacterium called Mycobacterium tuberculosis, and it forms little nodules all throughout the lungs, and those nodules are really difficult to penetrate because the bacteria live in those nodules. Hard to get to. Not only that, but the nodules are going to impact compliance, membrane surface area, and the ability to exchange gases. Tuberculosis is a big problem because we can't treat it with antibiotics because you can't get to the bacteria. They're anaerobic. They're tucked in those little tubercle tubicles, right? And so antibiotic therapy has to go on for close to 9 months. And very few people are compliant, which means that it gets carried on and spread. And it's a particularly bad disease in third world countries where they have a lot of non-compliance and a lot of close quarters and a lot of poor people. So tuberculosis is a big problem. Hopefully, it doesn't happen that we get a big surge of tuberculosis. What about emphysema? There's the air trapping. So here's a slide with big air pockets. And you'll notice that we got a couple of alveoli over here that are still intact, but lots of decreased surface area. There's an emphysemic lung. Look at those big spaces of alveoli where air is trapped. And it just swirls and swirls and swirls. And buildup of CO2 continues. Why is CO2 a problem in the lungs?
Hydrogen, decrease in pH. Decrease in pH.
A decrease in pH to the blood and then the cerebral spinal fluid. And your medulla says ventilate, but you can't
Yeah.
because you have all that CO2 buildup and you have no compliance. And you now have big pockets of this gas that's backed up into the blood. Gets back up in the blood because that's where it came from, right? Sheesh. Problem. Your respiratory cilia are paralyzed or broken, dead. Goblet cells increase, you get more mucus, even less surface area available. So chronic obstructive pulmonary diseases are very difficult to deal with. Then we have lung cancer. I don't know a lot about lung cancer. I know that there are some things that are more likely to cause lung cancer. Smoking, everybody knows that smoking can cause lung cancer. Did you know that smoking can also cause ectopic pregnancies?
What's that?
Ectopic pregnancy is where the oocyte that was fertilized gets trapped in the oviduct because the cilia, there's cilia along the length of the oviduct, and they're paralyzed from the smoke, from the nicotine. Just like the cilia of your respiratory tree are paralyzed when you smoke, and that's why the heavy smokers have that smoker's hack, right? They're trying to bring up that mucus all the time. They're constantly working and bringing that up and out. Anyway, lung cancer, any cancer can metastasize, and when it metastasizes, it goes to other organs, and those other organs are typically, as you see here, liver, brain, anywhere that heavy supply of blood's going. And we have a couple different kinds of lung cancer. As you see here, squamous cell carcinoma. And our squamous cell carcinoma is when those pseudostratified ciliated columnar epithelium are replaced with stratified squamous epithelium. Well, what good is that? You need the cilia. You need the mucus. Stratified squamous doesn't produce mucus. Yeah, so that's a problem. We also have adenocarcinoma, mucus glands. Where are the mucus glands? All along the walls of your trachea and your bronchi. Small cell carcinoma, one of the most dangerous, metastasizes quickly. But then there's mesothelioma. Have you heard of that? And I can speak to this one. Have you heard of it? So you all are probably lucky because you were born after asbestos was the thing in construction. Asbestos is the primary cause for mesothelioma. So my father-in-law died of mesothelioma. He was in the construction industry when he was a young man. So he was born probably around 1925 or 6, somewhere in that range. Young man, construction industry, asbestos was used for everything. Insulation, around piping, in paint, everywhere, yeah?
So is it asbestos fibers? Is
Yes,
that what that is?
yes. Little itty bitty, very small fibers. They work their way through the lungs and into the surrounding tissue.
I work at a hospital and like down in like our like lowest area, like the tunnels, what we call it, there's signs all over saying danger, danger, like asbestos fibers. I'm like, oh, okay,
Yeah.
great.
Very nice. So, he was exposed to asbestos. He died of mesothelioma. Unfortunately, he tried to fight it by having an entire lung removed. That didn't work out for him. He died pretty quickly after that. My mother developed mesothelioma. My mother was a children's nurse working in London during the Blitz. And the Blitz was when Germany bombed London during World War II. Asbestos in all those buildings. She had never smoked. She never was, exposed to asbestos that we knew in the house that we grew up in. Died of mesothelioma because of that bombing. So it takes years and years and years for mesothelioma to show up. And what it does is it fills that pleural space between the thorax and the lung. So it's not an intrapulmonary tumor, and it's more like a spaghetti-like tumor, so strands of tumorous material that presses against the lungs, of course, When your lungs are compressed, you can't get as much oxygen, so you have difficulty breathing. For years, she suffered, and we didn't know because nobody actually looked that way. We thought anxiety, high blood pressure. Her pressure was sky high. Yeah,
Are you saying asbestos or white
asbestos.
asbestos? That's,
Asbestos.
white asbestos is the plague, right?
I don't know.
Mhm.
Why
Yeah,
asbestos?
White,
the-
white asbestos?
It's a black plague, I believe.
The black plague, okay. I didn't know if you you were saying like,
White
it's not the same
asbestos?
thing.
Something like that.
Maybe I'm not saying it right. I can look it up. But that sounded like what you were saying.
Last slide. Lung cancer, normal lungs. Yikes. This is a smoker, a heavy smoker's lungs. Nasty. And that's that, gang. That's the respiratory system.